Hi, welcome to Bone and Soft Tissue Neoplasms. This is Dr. Bhavin Jankaria, and we're on case 51 looking at long femur disease. So, I had put this case up about 3 weeks ago, a 22-year-old who presented with pain and swelling of the right thigh for a month with a history of fall 3 weeks prior. And this was the radiograph. That was the MR, the coronal stir T1, coronal sag T2, post contrast, and then you have the two axials T2 and post contrast. That's the CT, and these were the choices. So the X-ray really doesn't show anything. The MR clearly shows a long segment lesion, lots of marrow edema. There's periosseous edema. There's some erosion of the anterior cortex. There's no collection, and there are these foci of fat sparing that we see on the T1 weighted image. The CT shows permeation. You could argue that there's a little bit of sequestration or very early cloaca formation in the cortex, but obviously it's abnormal. So if we look at all of these choices that we have, Ewing sarcoma is a difficult diagnosis when it comes to differentiation from osteomyelitis, especially when you don't have a large non-necrotic soft tissue mass. So we had this patient who had sclerosis of the femur, cortical thickening. The first diagnosis was osteomyelitis. He'd had an earlier surgery done. But one of the things that helps differentiate is that Ewing sarcoma is often very sharply demarcated, and the marrow edema wouldn't be that significant. And you see a diffuse periosteal reaction here. Again, this could happen with osteomyelitis as well. I had biopsied this, and this was Ewing sarcoma. So, yes, when you have typical findings of a collection with pus, that's osteomyelitis. Non-necrotic soft tissue would be Ewing's. But in these kind of situations where you have only bone involvement, it can be a challenge. And I discussed this entire thing at case 8 if you'd like to see it. Remember, all the cases are free, all access is free. You just have to click on the link and get there. The next would be this patient. You've got an osteolytic lesion in the diaphysis with a little expansion. It's dark, but extensive marrow edema out of proportion, cortical thickening. There's diffuse periosteal reaction with some periosteal fluid here, periosseous fluid, but no collection again. And this I had biopsied, and this was Langerhans cell histiocytosis. But this is a typical presentation: a younger patient, diaphyseal, no extraosseous spread, which again is important, and marrow edema out of proportion to the lesion. Um, then we have this entity, osteolytic lesion, subphyseal, metaphyseal, lot of edema, marrow and periosseous, but no extraosseous spread, no cortical break. And this I had biopsied, and then the patient had a whole body MR because they went to a rheumatologist who had made the diagnosis in their mind. And you can see all of these multifocal lesions everywhere, which tells us that this is chronic non-bacterial osteitis. Patient was put on pamidronate, and most of these lesions had regressed after a year. And I've discussed this in great detail with other cases as case 16. So that was non-bacterial or chronic non-bacterial osteitis. And stress fracture is usually not a problem. Here's a patient, you can see a little bit of callus formation and periosteal reaction with sclerosis. A lot of marrow edema here, but then you can make out the fracture very well. And then on the CT, you can see the fracture with the callus formation. Now, this was the spread of answers, and I can understand the issue differentiating Ewing sarcoma from osteomyelitis. But in our patient, it's definitely not a stress fracture. The marrow edema is too much, and there was absolutely no cortical area that looked like a fracture, and we've even given a CT scan. So this would be out. Chronic non-bacterial osteitis is also out. It's again too long a lesion, and you have cortical erosion, which you don't get with CNO. CNO basically presents as a focal marrow subphyseal lesion without extraosseous extension. LCH in our case again doesn't make sense because it's too long segmental lesion, and again you have um, the whole constellation doesn't really work. So, yes, if you said Ewing sarcoma, that's always a possibility in this patient, as is osteomyelitis. So I would say that about 41% of people got it right, but the rest didn't. And so I biopsied it, and it turned out to be Salmonella typhi osteomyelitis. So if you look at osteomyelitis, you can make a diagnosis on X-rays, MR, or CT. On X-ray, we'd see these findings here. So here's the osteolytic lesion in the distal tibia, another one in the distal femur. They usually have a wide zone of transition, and you may see a little bit of sclerosis. These are more typical findings: large osteolytic lesion with periosteal reaction. This one shows multiple cloacae and sequestra with periosteal reaction, and this patient has just this diffuse periosteal reaction. Of course, in this ulna, it's tough to make out what's happening, but in the others, you can make a diagnosis of osteomyelitis quite easily. On MR, you get all of these findings. The hallmark is marrow edema. Remember, you cannot get osteomyelitis without marrow edema. And here you can see these interspersed areas of fat. These are those fat globules that are either just there or the spared fat, and then we see a lot of the soft tissue here. This is an intraosseous collection. There's a T1 bright wall that is seen across the body when you have collections. Again, see the marrow edema from here all the way up to here. And then here's a collection around the bone. And then, of course, there is extensive marrow edema as well. So this patient had an abscess which I had aspirated. On CT, we'd see similar findings. So here are these osteolytic lesions, wideish zone of transition, periosteal reaction, and a sequestrum seals the diagnosis whenever you see it. Those sequestra are more common with tuberculosis than non-tuberculous infection. Here's another patient, a 60-year-old. You can see this permeative lesion with sclerosis and osteolysis. Just on the CT and the X-rays, you might even consider a diagnosis of lymphoma or sarcoma. But if you look at the MR, you see all these fat globules on the T1 weighted images. This is very typical of osteomyelitis. And then these areas of necrosis and the effusion. I went straight into the bone, biopsied it, and it was Staph aureus. And this is another patient who has these collections within the bone and outside the bone. And I went into one of these areas, and again, this was Staph aureus osteomyelitis. So our patient had a long femur disease, which turned out to be Salmonella osteomyelitis. Don't forget the index. Now we have 51 cases, including this one, and many, many lectures. That's a link to my WhatsApp channel. And for those of you who would like to go through my other sites and cases, I put up this lecture about 3 or 4 days ago. This was last week, where I talked about the various approaches to retroperitoneal nodule and nodal biopsies. This was again earlier in the month, where I've put together the rheumatic mitral disease and a bicuspid aortic valve in the same patient. This was yesterday. But I said, even if you're physically active, you also need to reduce your the time spent being sedentary. You know where to comment, email, subscribe, etc. And thank you so much for listening to me. Do share this with anybody you think would benefit from this. Thank you.